Thanks for the introduction and a warm thank for inviting me to this stimulating symposium, which made me at least think a little bit out of the box. Because the title given to me, Why Doctors Look at the Wrong Organs, is something I thought about for some weeks before I tried to approach it. But let's see. When doctors look at people, we maybe see other organs than what they perceive. But I will not go into detail there. But just briefly start with an ongoing case from my ICU. He's still there. 68-year-old male, previously treated for Crohn's disease, and he was immunosuppressed. Another ileocecal resection in '85. He then developed the last year an adenoma in colon and was admitted for planned surgery in January this year. Well, I have the same problem with shake it. The first operation with resection of ileum and 3/4 of the colon, the surgeon noted that it was a difficult surgery because of a total adherent abdomen. And of course, what happened must happen. 5 days later, he had a second operation because there was a perforation during the first operation. He was in septic shock with peritonitis, emergency operation, and massive fecal soiling. And what happens next? He had, of course, a massive traditional multi-organ failure, mainly circulation, lung, kidney, received several vasoactive drugs, of course was ventilated, and had also a hemoperfusion with a specific filter designed for removing endotoxin. Gradual improvement during the first days and could in fact be extubated on then day 10. But 2 days later, again an abdominal leak with new laparotomy. And this time they had to resect most of the small intestine, so now he's left with 180 centimeters of intestine. And again, new laparotomies on day 17, 19, 20, and also the 22nd, which happened after I made this slide, and with still an uncontrolled leak from his abdomen. But he was extubated, and no recurrence of his organ failure in the beginning. But this is what he looked like when I left the unit yesterday. As you can see, he has an open abdomen, severe gastrointestinal failure. He has soiling and leaking everywhere. And in addition, what must come that late, he was delirious. Went in and out of the delirium. He knew he was delirious, so he told us, no, I'm seeing this and that. And that made me come up with another picture of delirium. And this is, in fact, made by an artist called Kurt Vestergaard, who is more famous maybe for these Mohammed drawings he had in 2005. And he's still living protected in Denmark from people who wants to kill him for that. He was present at the dissertation in Denmark because he had delirium in the ICU where that nurse who had her PhD thesis on delirium worked. And the distorted time is very well illustrated there. What I want to show you is that this is our traditional way of looking at organ failure. This is SOFA score, and this is taken from our intensive care record. We calculate, or the system calculates SOFA score every day. We can see he started out with 11, 10, went up a little bit, and then gradually down. And the last picture was taken here when he had a SOFA score on 2. But still, he is in multi-organ failure, but from the organs we seldom think about. So why has it come to this, that we seldom, there are organs that are popular and there are organs that are less popular? Well, it all started 50 years ago and as often in United States, this is the first maybe systematic review of what they then called sequential system failure. And the problem was abdominal aortic aneurysm, acute ruptures. As we see here, there is a lot of organs, pancreas, lungs, liver, CNS, lower GI, upper GI, that was listed as systems. And of these 17 patients that was described, 1 survived. And there was also the first start of trying to put this into a context, the interrelation. Today we will probably shake our heads about some of these interpretations, but oh, I'm not going back. Yes, but it was a start. Although hypoxia today probably not only affects hearts and lungs. Then 19 years later, system was changed to organ. And then we have this very famous publication by Deitch, where he introduced the multiple organ failure and described pathophysiology and potential future therapy. Dysfunction and failure were both introduced here, although we today more often talk about failure. Pulmonary, hepatic, renal, intestinal, hematological, CNS, and cardiovascular was included here. He also introduces some of the paradoxes we still live with, and I will not go into detail here. We are on overtime, and I think more than me are longing for a cup of coffee. And also a revised mechanisms of what was behind this multi-organ failure or dysfunction syndrome. The interesting thing is that during the time, the concept of organ failure has developed from including a lot of organs with the Tilney paper of the aortic aneurysms in 1973 through the SOFA score, Jean-Louis Vincent co-workers in 1996. And interestingly, the intestinal system had completely disappeared from our list of organ failure. The muscular system, with regard to the last speaker, is not there yet either. So, why? None of the commonly used organ failure system deviates from this traditional view. It's not only the SOFA score, it's also the Lodz score and the Marshall score. They all have these 6 vital organ systems that we are more or less indoctrinated with. And this may be an important reason that why we do not look outside the box and accept this as granted. We sell it to our students, we sell it to our juniors, and this is what they look for. So what's then outside the box? As I've already said, we have the gut, the intestines, we have the neuromuscular system, which we heard a lot of in the last speak, the immune system, and we have a lot more of the brain. And multiple organ failure. This is a very good paper by Mervyn Singer and Nicholas Mogadon about MOF being a transient adaptive state in critical illness, more into the immune gate that we heard. So, think about this. Which is the first organ that fails? What do you think? I won't demand an answer, but you can have some seconds to think which is the first one. Well, this was studied by Rui Moreno and co-workers some years ago. And as you can see, it's the brain. The neurological dysfunction comes first. This is from a sequential following of SOFA score of a large cohort of patients. And the brain starts, the rest follows. And the hepatic is a little bit slow to develop. And often the last organ function to disappear, it's also the brain, with delirium, cognitive dysfunction, all this stuff that we have heard about. So how do we then assess brain function when you think about organ scoring? We use the Glasgow Coma score, and it has been unchanged since its introduction by Teasdale in 1974, and has more or less acquired a monopoly on how to assess brain function, at least in large cohort of physicians, maybe not those who work directly with the brain on a daily basis. In fact, the GCS is nothing but a grading of coma. And we must admit that the brain has a lot of other functions than merely keeping us awake. And one of the more important, which we've heard a lot about this day, is keeping us on the right track, not deviating from the normal. Because if this fails, we develop delirium, often in spite of having a GCS of 14 to 15, because it's intermittent. So allow me a little delirium off the track. What's the origin of the word? Anyone who knows? You know?
It's Latin, delirare, getting off the track.
Very good. De is away from. Lira is, in fact, a plow furrow. Not a track, but it's a plow furrow that the farmer in old Rome made by their ox. Eum is a usual ending in Latin words. So delirium was the concept. If a farmer did not follow the plow furrow, deviated from the track, he conducted a delirium. And the term was first used outside this box by Celsus in the 1st century after death. So now you know where it come from. But you were the first. I've asked this a number of times in dissertations. Nobody knows, but you knew. I'm impressed. And delirium, as you've heard, is very, very common. This is incidence of delirium since 2001. I took it from the PhD thesis of Svenningsen, this nurse who had her thesis about delirium. The red is the median, and we see the median is around 40% in a long range of studies having looked at delirium. And the consequences of delirium are clear. We have increased patients with death, and this BMJ meta-analysis clearly concluded that delirium is strongly associated with increased hospital mortality, probably also long-term mortality, as you can see here. So the brain is too complex for a unidimensional description of its function, but we still are stuck with it because we have nothing better. But this is really a challenge for the intensive care societies, for the intensivists all over, to try to come up with a better methods to assess brain function in our ICU, and a simpler method than just burying holes and looking at intracranial pressure, for example. Well, the gut. My patient initially showed that this was a problem, but the gut has for a long time been an interesting organ in the start of multi-organ failure. So with it, alteration and structure of function of mucosal barrier are thought to play an important role as a source of bacterial products and inflammatory mediators that come from the intestines and systemically and damage various organs, including the gut itself. And that's why some, in particular in the Netherlands, have used systematically the selective decontamination of the digestive tract. It has, for some reason, not spread around the world. But maybe we should again think about it, because it's been shown to reduce the number of patients with multi-organ failure. It's this publication from 2010. And it also decreases the intensive care and the hospital mortality in patients who are given selective digestive decontamination, and in particular the digestive part may be not so much the oropharyngeal part. So here is the syndrome you talked about, or the sarcopenia. So you have said a lot. I will just follow up a little bit about the muscles as a very important organ. So muscle weakness, as we heard, is prevalent in our patient, and it's a very complex disorder as a group, if we can call it muscular dysfunction or muscular failure, because it's often present at admission as could be a primary muscular disorder, could be sarcopenia, as we've heard. And it becomes more evident during intensive care. It could be the ICU-acquired myopathy or neuromyopathy that we all have seen. But catabolism in itself, stress metabolism, digests muscles in order to create glucose. Even though we give the patient glucose in the nutrition, still this stress metabolism decomposes muscles every day. And on the top of that, we have the activity, of course. So this means that at discharge of the ICU, muscle weakness is very, very common. And it's often evident very long time after hospital discharge, and at least in my post-ICU follow-up experience, they very often have problems with muscular activity. They feel weak. And the good or bad things about muscle weakness is that partly it's an iatrogenic thing, because these four things I've listed here, inactivity, heavy sedation, inadequate nutrition, and drug-induced by using steroids, neuromuscular blocking agents, etc., all this can add up with increased muscle weakness. I will not go into detail here because the previous speakers have said a lot of this. But in particular, heavy sedation, where I come from, this is a plague. Many units are far too fond of patients lying quiet in bed, and they sedate them thereafter. So what can we do to prevent it? Stop harmful sedation. We can, even with an oropharyngeal tube, we don't need to do tracheostomy in all these patients, have an awake and cooperated patient if the patients are painless, or at least given a lot of good analgesics. And we can also activate and mobilize our ICU patient, even though those who can't get out of the bed. So this is sort of a bicycle machine. It can also passively cycle the patient, but he or she can also actively use it as long as the strength recovers. Does this work? This is just one of the 4 studies that was shown previously. The first one from Lancet 2009. It was a small study, but very well performed, with a significant reduction of mechanical ventilation, length of stay in the ICU, and a length of stay in the hospital. But if you look a little bit up here, we also see that this had effect on delirium, time in ICU with delirium, and time of hospital delirium days. In this rather small study, they found this rather strong signal. So, back to the initial question given to me, why do doctors look at wrong organs? First, let me say wrong organ is a context-specific term. In the start, for example, of the septic shock I showed you initially, insufficient oxygen delivery is not wrong to concentrate on circulatory failure. But maybe better ask why we do not have a more holistic view of organ dysfunction with regard to the requirement of our patient. The requirement at discharge is very different than the requirement at admission. So probably our focus have been very much on the popular organ failure, circulation and ventilation in particular, And this somehow distracts us from looking at the entire patients. The focus on these other organs in congresses, journals, and elsewhere is less intense, and this later will be adapted in the clinical setting in our ICU, in our junior doctors and physicians. This is a book I stumbled over in a bookshelf in London. How It Works, Book of the Vital Organs, may be worth reading. Thanks for listening to me.
Thank you very much, Hans. When you were talking about guts, I thought, now, Hans, you made my day, because I'm going to make that comment coming from the Netherlands, but then you have made the comment yourself, so I don't have anything else anymore to say. Before asking a question to the audience, I was very interested when you said that also in the ICUs around you, the people have the tendency of sedating the people a bit too much, and that's exactly the problem we have in the Netherlands. While I've been to a couple of ICUs in England, you see the patient, although still in the critical phase, sitting on a chair and brushing his teeth. Where is this coming from? Because, I mean, if it would be in Southern European countries, we would say they don't have too much finances, the nurse-patient ratio is too high, but that's not the case, at least in Norway, and to a certain extent not in the Netherlands.
No, I agree with you. It's a puzzle why we have to sedate our patients so heavily. I think at least many of my nurses think that that's the most humane for the patient to be unconscious during all these terrible events. But the fact is the opposite, which we know a lot of, that if they just remember fragments, this may be a very strong inductor of post-traumatic stress. It's better to remember the whole story, and that's why we write it up and do diaries today, to make them available and aware of everything that happened, even with photographs. So it's a puzzle, I agree, in particular in a place where we have 1-to-1 nurse ratio, and as we have in Norway.
Any questions from the audience? I know that you would like to have really a cup of coffee, but...
I think we are going to have a break after the last question. Please.
Where was it? Oh, there, thank you.
I particularly liked your presentation, and to coming back to the initial questions, why do the doctors look at the wrong organ? Basically, every doctor looks at the organ he or she knows best. That's the truth, I should say. And so I think geriatrics and intensive care medicine are special in a way, as they tend to look at functioning of the whole context, like getting scores for the whole organ systems community. And so maybe geriatrics and ICU medicine are very similar in having this scorological look at the community of organs working together. So.
Yes, and some of my new research friends are in fact geriatricians now, because we are looking at the octogenarians, what happens to them, and I do think we can do a very good job together.